Welcome to Cardiac Sciences Grand Rounds for Tuesday, June 4th on this beautiful, what's actually starting to look like a summer morning. So that's fantastic. Today we have one of our own coming back to give us a talk on stress echo, Peter Zhang. Peter did his core cardiology training here. Most of us know him through those years. In this past year, he's been up in Edmonton doing an echo fellowship and spending some time on stress echo as well. So this morning, he's going to speak to us about stress echo and how he feels a program should be set up. So Peter, welcome back to Calgary, and we look forward to hearing from you. Peter will be joining staff come this fall, part of.
Thank you for that warm introduction, Dr. Howarth, and great to see lots of familiar faces and also great to see new unfamiliar faces. So I look forward to working and meeting all of you. So I've been very privileged in the last year to be able to work at the Mazikowski Heart Institute and learning from a lot of talented sonographers and echo readers there. Being immersed in their echo lab there has definitely taught me a lot. And one of the techniques I definitely learned a lot was stress echocardiography. And the reason why I wanted to give this talk was because during my training here, I felt like I didn't get a lot of exposure to it. And then after learning in Edmonton, I feel like it's definitely a technique that we could be certainly utilizing more in Calgary. I hope by the end of the talk, I can convince you all that stress echocardiography is a powerful yet very versatile test. We'll touch on the key indications for ordering a stress echo, what are some of the common stress protocols, a little bit about image interpretation, and also importantly, what to do with that information. So in terms of disclosures, I don't have anything to disclose. Our talk today will be mainly drawing from the ASE 2020 stress echo guidelines. We'll also be talking a little bit about data from the 2020 ACC valvular disease guidelines, and also a tiny little bit from the 2014 CCS stable coronary artery disease guidelines, but those are a little out of date. So for interest's sake, I pulled a random month's stress echoes from the echo lab at the Mazikowski. In the month of March, we performed 43 stress echoes in total. The vast majority was for ischemia as an indication. The next largest group being post-transplant monitoring at 16%. Valvular disease accounted for a small fraction at 7%, and then the smallest fraction was hypertrophic cardiomyopathy, where we were looking for LVOT gradients, where there was none on the resting study or even with Valsalva provocation, and that was out of keeping with the patient's symptoms. We'll start from the older guidelines first. This is the 2014 CCS Management of Stable Coronary Artery Disease Guidelines. So in terms of whether or not a stress echo is indicated, you can see that whether or not the first question we have to ask is whether or not the patient is adequately able to exercise, and then whether or not there are ECG abnormalities. If there are some, then the imaging modality is usually more preferred over a stress ECG test. If there's no left bundle branch blocks or ventricular pace rhythms, then the exercise echocardiography can be performed alongside other things like myocardial perfusion imaging. On the other hand, if the patient is not able to exercise and the ECG is either normal or abnormal, and again, without any left bundle branch blocks or a ventricular pace rhythm, then the dobutamine stress echo can be performed, so a pharmacologic stress echo. However, that is based on older data, and the more recent data from the 2020 ASE guidelines does state that a left bundle branch block, as well as pace rhythms, are quite safe to do a stress echo in, and also they do not necessarily negatively impact our findings. And besides the usual indications of intermediate coronary artery disease risk with symptoms for risk stratification, other areas where stress echo can excel are when the patient again has baseline ECG abnormalities that will make a stress ECG difficult to perform. And then also in women and children who require risk stratification, it's a preferred method due to the lack of radiation exposure. And there are some more recommendations about patients who are unable to exercise who should receive a pharmacologic stress. And another big indication, and certainly we do a lot of these studies in Edmonton, is that in patients with exertional dyspnea of uncertain etiology, stress echo is a very powerful modality, as we can also screen for valvular disease, pulmonary hypertension, as well as diastolic dysfunction. There's some more recommendations, such as using stress echocardiography when the ECG stress is inconclusive. Otherwise, there are some recommendations there that you can refer to for reassessments of stable coronary artery disease, as well as for preoperative risk stratification. So compared to the other common modalities, stress echo has a very similar sensitivity and specificity. You can see that exercise or pharmacologic stress, and that is without contrast, comes in with a sensitivity of 79% and specificity of 84%. With the addition of an ultrasound contrast, the sensitivity increases to 84%, which is very comparable to nuclear modalities, while still having a very good specificity, although the specificity goes down a little bit as we can get more false positives when we use a stress agent, or when we use a contrast agent rather. And although stress echo has let me back up a sec. On the other hand, stress echo also has a very high sensitivity for detecting left main disease or multivessel coronary artery disease, where balanced ischemia can make it difficult to interpret a nuclear study. And another point to consider is that a lot of these comparison trials don't necessarily consider the incremental value that an echo adds in terms of additional information in regards to diastology or valvular disease or pulmonary. Stress echo can also be used for viability studies, besides just ischemia. And certainly, while FDG PET has the highest reported sensitivity for detection of viable myocardium, SPECT and stress echo are still very powerful methods. And this table looks at all the things that are considered when we do different imaging modalities and what we look for in terms of viability. While SPECT tend to have a better sensitivity than dopamine stress echocardiography, dopamine stress still has better specificity for predicting viable myocardium. Primary sign that we're trying to detect with stress echocardiography is an improvement in LV function, or in other words known as contractile reserve. While there isn't a specific target that we're looking for improvement in contractile reserve, like in the case of low flow, low gradient aortic stenosis, it's more of a qualitative improvement of wall motion with stress. So getting onto the valvular indications, certainly the primary valve disease for which stress echo is known is low flow, low gradient aortic stenosis, where with adequate contractile reserve, defined as increase in stroke volume of 20% or more, combined with compatible changes in the calculated valve area as well as transvalvular gradients, can make a diagnosis of true severe aortic stenosis versus pseudo-severe aortic stenosis. In patients who have paradoxical low flow, low gradient, where you have normal LV ejection fraction but reduced stroke volume index, stress echo is also very valuable in making that diagnosis of pseudo versus a true severe. In terms of other aortic valve disease, in asymptomatic severe aortic stenosis, certainly stress echo can be used to see if we can reproduce any symptoms and thus make it a class 1 indication for the patient valvular replacement. Other additional metrics we can look for are blunted blood pressure response, as well as an increase in mean gradient across that aortic valve. For aortic regurgitation, this is more chronic primary aortic regurgitation. The main value here will be looking for symptoms. Mitral valve disease, and kind of similar to aortic regurgitation, in patients with chronic primary mitral regurgitation, we can perform a stress test to look for symptoms. And there is some data from the older 2006 ACC valvular guidelines where if the PA systolic pressure goes above 60, there is an indication there for a valvular intervention. On the other hand, stress echo is very powerful in patients with mitral stenosis, where in those who have asymptomatic rheumatic mitral stenosis, a PA systolic pressure that goes above 50 millimeters mercury is a 2A indication for balloon commissurotomy. A little bit less helpful in patients with less than severe mitral stenosis, but it's still a 2B indication to look for hemodynamically significant mitral stenosis, which is defined as a gradient of more than 15 millimeters mercury. Otherwise, in terms of the other valves, such as the tricuspid valve and pulmonic valve, as well as in patients with prosthetic valves and adult congenital heart disease, the role of stress echocardiography is a little bit more niche, which we won't touch on today. In cases of hypertrophic cardiomyopathy, stress echo has been playing an increasingly prominent role. It's often used to inform the degree of LVOT obstruction with exertion, especially when symptoms are incompatible with the findings we have at rest. And the data has shown that LVOT obstruction developing at lower levels of stress is associated with a higher degree of functional impairment and worse NYHA class. And certainly for the indications of ischemia, stress echo is superior over stress ECG. As we know, a lot of these patients, while baseline ECGs are confounded by conduction abnormalities. the heart transplant population. At the Mazankowski, it's the standard of care to perform dobutamine stress echoes on a yearly basis as part of the patient's regular post-transplant surveillance. And the reason we're doing that is to screen for cardiac allograft vasculopathy. The literature has shown that the sensitivity of dobutamine stress is more than adequate to reduce the need for repeat coronary angiograms as well as intravascular ultrasounds in the case. However, the sensitivity of stress echo in these patients is strongly tied to whether or not we're able to achieve adequate hemodynamic stress in order to detect subclinical and significant disease. On the other hand, performing a stress echo in this patient population can sometimes be difficult as their heart rate response can be very variable in that some patients might achieve their target heart rate at a very low dose of dobutamine, whereas others will struggle even at maximal doses. And one common practice is that if we're having difficulty achieving our target heart rate at 85%, we would give a little bit of dobutamine. However, the use of dobutamine is very limited in this population given cardiac need innervation. Before we commence a stress study, we usually perform a limited baseline study, especially if the patient has not had a recent echocardiogram. The reason is to screen for other causes of the patient's symptoms, such as aortic stenosis, mitral stenosis, pulmonary hypertension, as of yet unrecognized cardiomyopathy, such as hypertrophic cardiomyopathy. And also, it's important to look for any wall motion abnormalities, as that has an effect on the choice of stress protocol. In terms of the oldest stress protocol used, this will be the treadmill, and it's typically done by the Bruce protocol. And in patients who are able to exercise, certainly exercise stress echo is preferred as it preserves the normal electromechanical response. It also provides us prognostic information with regards to their functional class. And like I mentioned, the Bruce protocol is the most commonly used, where we use 3-minute stages of increasing difficulty on the treadmill until exercise limiting symptoms are achieved or there are significant abnormalities in the blood pressure, heart rate, and or ST segment changes. At that point, the exercise is then terminated and the patient's brought onto the stretcher for the echo study, and the images have to be taken very quickly, as within the first couple of minutes, regional wall motion changes can start to normalize. The upright or supine bicycle can be used as well, and it's actually the primary stress exercise protocol that we use at the Mazankowski. Here's an example protocol, except the protocol that we tend to use 3-minute stages as opposed to 2-minute stages. Primary advantage of bicycle over treadmill is that it allows simultaneous imaging during stress, as the patient's torso remains relatively mobile. Again, we continue this until exercise limiting symptoms or until we reach target heart rate. But the addition is that also if we see significantly abnormal wall motion abnormalities on echocardiography, then we can also terminate the test. Generally, we terminate the test after reaching 85% maximum predicted heart rate and after we acquire the peak images. But there is data for continuing stress to the point of developing symptoms, which further increases the sensitivity of the test and might uncover abnormalities that would have otherwise been not detected. And data that shows an inability to reach 80% of maximum predicted heart rate reduces the sensitivity of the test, however, so it's very important that we reach that 85%, more so than dobutamine stress echocardiography. In this population, certainly atropine can be used to augment the heart rate, and the heart rate will recover relatively quickly. But the main side effects that patient needs to be aware of is pupil dilation. So generally tell people that they can't drive for the rest of the day. And as you can see, the starting workload is typically 25 watts, but certainly we can start at a lower wattage in those with resting regional wall motion abnormalities, and that helps us to better inform on viability, which we'll talk about in a little bit. Some other measures we can take on stress echo besides just LV ejection fraction as well as regional wall motions are listed very neatly here on this diagram, as well as which appropriate stages we can measure them at. Measuring a patient's hemodynamic response can give us lots of insight as to whether or not their symptoms are truly due to ischemia or due to other issues such as diastolic dysfunction. And certainly diastolic dysfunction can often be uncovered before the manifestation of systolic wall motion changes. Where applicable, diastolic function should be measured at baseline and then during a stress protocol. In the case of treadmill exercise, because we're unable to image them during the stress, this should be done just at or just after the peak exercise stage. However, assessment of diastolic function is limited by heart rate and generally above heart rate of 90, this can lead to fusion of the E and A waves, which will make it difficult to interpret. And then other measures that we can look at, so related to pulmonary pressures, we can look at the tricuspid regurgitation velocity with stress, as well as pulmonary valve velocities. Other measures also include mitral valve deceleration time and LA volume index, which gives us an idea of left ventricular filling pressures. And of course, mitral regurgitation severity in cases where we suspect there might be ischemic MI. In terms of pharmacologic stress, this can be carried out with either dobutamine or vasodilators. However, dobutamine is most preferred due to a wealth of data, as well as superior sensitivity. This is a very common protocol here where dobutamine is given in graded stages in 3-minute intervals, up to a maximum of 40, but in some cases we can go up to 50 to reach target heart rate. Generally at the Mads-Mikkelski, we start at 10 micrograms per kilogram per minute if there are no baseline abnormalities. Whereas you can start at a lower dose, such as 5 or even down to 2.5 when you detect baseline regional wall motion abnormalities, as again, this helps us to better inform about viability. Atropine certainly can be used to augment heart rates, and this is usually given a dose of 0.25 or 0.5 milligrams every minute or so, up to a maximum of 1 to 2 milligrams. In this patient population, it's very helpful to be able to withhold beta blockade if at all possible, provided it's safe, as the beta blocker will certainly counteract our dobutamine. And the dobutamine stress endpoints are similar to those of bicycle exercise. And dobutamine, as we know, has arrhythmogenic potential, and there's data that it can generate some degree of non-sustained VT or atrial fibrillation, but these tend to be fairly self-limited and self-resolve. In terms of vasodilator stress, this can be achieved with adenosine or dipyridamole, and again, can be used to assess for ischemia, perfusion, as well as viability. Of course, as we know, these are contraindicated in patients with severe reactive airway disease, as well as hypotension. But often DSC is preferred due to a higher sensitivity for coronary artery disease detection, unless perfusion is also assessed at the same time. So hopefully that video is not too choppy there. Visual detection of regional wall motion changes is the primary method of analysis on stress echocardiography. The regions of the heart, myocardium, which are supplied by obstructed coronaries, are identified by reduction in their wall motion, or relative hypokinesis compared to more hyperkinetic normal segments under stress versus at rest, or compared to other segments which have a normal blood supply. Besides just wall motion alone, I think that's not playing. Besides wall motion alone, wall thickening is also a very crucial tool in deciding on a wall motion abnormality. For example, in certain regions of the heart, such as the basal septal segments or the basal inferior segments, the wall motion can be reduced due to tethering to the mitral aortic curtain, but their thickening should still be preserved. Also, thickening is a powerful tool for detecting small areas of ischemia, which were otherwise tethered to non-ischemic regions, which can make the wall motion difficult to interpret. And as those normal segments become hyperkinetic with stress, those small regions can be missed if one is only looking for movement. Another phenomenon is called tardokinesis, where ischemia delays the onset of contraction, but caution should be taken not to confuse this with other causes of dysynchrony, such as, go back to the slide here so the image. So the one thing I want to demonstrate with the figure here is that this is the two-chamber view. You can see that on the right side here, which would be the anterior wall. At rest, there's already relative hypokinesis. And with stress, you can see a lack of not only movement, but also meaningful thickening, and that the contraction is delayed, so tardokinesis. The wall motion grading is performed with a 16 or 17 segment apical wall motion model. And each segment scored from 1 to 5, with 1 being normal or hyperkinetic, down to 4 being dyskinetic, and 5 being aneurysmal. Thinned areas generally represent areas which have had transmural infarction and scarring, are defined as areas which are less than 70% of the thickness of the normal segments, or an absolute thickness of less than or equal to 6 millimeters. Wall motion index can be calculated by dividing the sum of score of all the segments and divided by the number of segments measured. And that can give us a bit more of an objective measurement. So this image has gotten corrupted a little bit, but hopefully we can still get the point across. In all the modalities besides treadmill exercise, we can simultaneously perform imaging during stress, early stress, late stress, as well as during recovery. And this improves our assessment of the severity of coronary artery disease and improves the sensitivity. Early wall motion changes at lower doses of stress are indicative of more severe coronary obstruction with little to no perfusion reserve. Comparing low versus peak imaging has additional diagnostic value for detecting more intermediate lesions, especially in the cases when we use dobutamine stress or bicycle stress. In cases of moderate obstructions, with some preservation of perfusion reserve, one can see an increase in thickening of wall motion at low doses of stress due to an increase in blood flow. But at high doses of stress, the combination of tachycardia as well as coronary obstruction leads to reduced subendocardial flow and subsequently results in a decrease in the wall motion thickening. This is what we call the classic biphasic response, and its identification improves the sensitivity of a stress echo for the detection of coronary artery disease. That's what this figure here is showing. It might be a little bit difficult to see, but this is the apical four-chamber view at rest. You can see the lateral wall, there is relative hypokinesis, which does improve at low and intermediate doses of dobutamine, but at peak, again, the wall motion becomes hypokinetic. But given that we're able to continuously monitor wall motion throughout the stress protocol, this also allows us to determine the ischemic threshold, which is the heart rate at which the patient starts to experience wall motion abnormalities or symptoms. And this not only has value in estimating the severity as well as the extent of disease, but also gives us further risk stratification information. Lastly, imaging and recovery also gives us lots of information. Similar to ST changes that persist into recovery on an ECG stress, wall motion changes that persist into recovery is indicative of stunning and more severe ischemia. So late recovery images should also be performed in those who have fairly extensive wall motion abnormalities. Sometimes during dobutamine stress, regional wall motions can be detected during recovery while peak function was relatively normal. So especially in those with a higher pretest probability who have a normal peak stress images, they should also have a recovery set performed. And I should note that imaging during recovery is one of the major advantages of stress echocardiography over nuclear modalities. So this is a table from the ASC that documents different types of responses to dobutamine by dysfunctional myocardium, and this is part of our viability assessment. So segments which are stunned, hibernating, remodeled, and in those with limited non-transmural infarcts are expected to exhibit contractile reserve, as in they are expected to improve their function with low doses of dobutamine stress. Improvement in two contiguous segments is usually what we look for, as this is more helpful than improvement in one isolated segment. Viable myocardium responds to high doses of dobutamine a variety of different ways, depending on the presence as well as the extent of non-transmural infarct and the severity of coronary artery obstruction. We expect hibernating segments, so segments which are expected to improve with revascularization. We expect them to exhibit a biphasic response in the vast majority of cases, however. Next figure is the apical two-chamber view. You have the rest stage here, and then followed by low, peak, and then post-stress, so early recovery. You can see that the inferior wall is relatively hypokinetic. There is improvement in contractility at low, which persists into the peak and not worsen again. So we would not call this a biphasic response. So wall motion abnormality at rest that improves with dobutamine is considered non-transmural infarct. So as I've just demonstrated, segments which have a sustained improvement, they have been shown to less likely to have significant functional recovery with revascularization. And besides non-transmural infarcts, these segments could also potentially be remodeled. Other segments which improves only at high doses of dobutamine are likely to have more extensive non-transmural infarcts and likely have little to no prospect of functional recovery with revascularization. Small minority of segments may have resting hypokinesis with worsening of function even at low doses of dobutamine. Myocardium this myocardium is likely partially viable and has severely reduced perfusion reserves and are associated with more severe multivessel coronary artery disease and an. So this is an apical four-chamber view, and we only have the rest images as well as the low stress. You can see that the lateral wall, again, is hypokinetic compared to the septal wall, and there is a worsening of lateral wall function with almost akinesis and a low dose of dobutamine. In terms of the data for dobutamine stress echocardiography and viability, there's been numerous studies that demonstrated that varying low and high doses of dobutamine imaging, they have very clinically useful sensitivity as well as specificity for detecting viability. False negatives can occur in hibernating regions which have disrupted contractile proteins. And on dobutamine stress echo, these may not necessarily respond to dobutamine, but there's some data that shows that eventually with vascularization, there is some degree of functional recovery months down the line, likely due to reorganization of the contractile proteins, but this is a very small minority. Prediction of viability by dobutamine stress echocardiography also has a high sensitivity and very reasonable specificity in the prediction of improvement in not only global function as well as clinical outcomes for the patient. In terms of right ventricular assessments, certainly the majority of our effort is spent on the left ventricle, but we can also perform a right ventricular assessment when we're looking for a right coronary artery disease. This is often done in an apical four-chamber view, but off-axis imaging can also be done to get a more RV-focused view. One of the more objective measures we use is the TAPSE, which is the tricuspid annular plane systolic excursion. This is measured by M mode, and there's data that shows a decline in the TAPSE by more than 4 millimeters has a reasonable sensitivity for proximal RCA obstruction. The clip I've attached here is of a patient that has undergone treadmill exercise, and this is their baseline imaging compared to post-treadmill. You can see that there is a reduction in the excursion tricuspid annular plane. Also, there's an increase in the right ventricular volume with stress, and this patient was cathed and found to have a proximal RCA obstruction. So this is a table here looking at the normal and ischemic responses to various modalities. A typical response to dobutamine is a marked increase in regional and global contractility, which, as well as a prominent decrease in LV cavity size due to reduced pre and afterload. Compared to that, treadmill exercise tends to lead to reductions in end systolic cavity dimensions, but generally less increase in contractility versus dobutamine. Bicycle leads to less increase in contractility than the above two methods, as well as less decreases in cavity size due to a higher preload as well as afterload relative to the other modes of stress. So this should be taken into account when, especially when a patient gets different types of stress echo during their workup. An absence of hyperkinesis, particularly with treadmill and dobutamine and vasodilator stress, can indicate the presence of significant coronary obstruction, but it's not necessarily specific for this. It can also be seen in patients with microvascular disease, hypertensive response to exercise, as well as underlying cardiomyopathies. Presence of left main or multivessel disease. In the presence of left main or multivessel disease, a stress reduction in LV ejection fraction or an increase in LV end systolic volume are more commonly seen in exercise rather than dobutamine stress echo. What I have here on the next slide, this is the apical four-chamber view. Stages labeled there. These are all acquired in the post-exercise and early recovery period. You can see that that with stress, there's a marked reduction in ejection fraction as well as an increase in the phenomenon of transient ischemic dilatation that we see in nuclear. So although SPECT is considered the modality of choice for perfusion, both SPECT and PET are limited by spatial resolution, higher costs, as well as radiation exposure to the patients. There are some studies from the States that estimate around 9 million SPECTs are done annually, and they contribute around 7,400 cancer cases per year. Other limitations of nuclear imaging modalities would be breast and diaphragmatic attenuation, which can impact our interpretation of the anterior and inferior walls perfusion. especially with vasodilator stress. Radionuclide tracers primarily detect changes in blood volume, which are considered less sensitive than changes in blood flow for detecting physiologically relevant coronary lesions. One of the techniques I certainly had a chance to learn in Edmonton was looking at perfusion with echocardiography as well. So the technique uses a continuous infusion of ultrasound contrast, such as DEFINITY, and it's called real-time low mechanical index flash sequence, which is quite a mouthful, but it's better known as myocardial contrast echocardiography. Look at tissue perfusion alongside wall motion changes and further augments the data we get. So typically with a stress echo, we have the echo contrast, which are tiny bubbles that are mixed in with the blood, which light up the LV cavity, but also the walls become brighter due to the infiltration. Blood mixed in with contrast. And what this technique does is it uses a pulse of a high intensity ultrasound wave to destroy the bubbles. And then we take the images after the flash to look at the heart by looking at the contrast re-entering the myocardium. So in this patient who has had a relatively normal flash, so early post-flash, you expect the myocardium to be quite dark. And as the contrast makes its way back into the myocardium, it should light back up similar to pre-flash. But after this patient who has undergone stress, you can see that with the flash, there continues to be a rim of subendocardial darkness, which is indicative. And these are their rest as well as stress images. You can see that this area of reduced perfusion exists even in an area without significant wall motion abnormality. What makes this method so valuable? So physiologically, this allows us to look at the myocardial blood flow changes during all stress modalities, as opposed to blood volume changes, which are detected on stress cardiac MRI and nuclear modalities. There are quantitative and analytical methods out there, which I'll only touch on briefly. Finding and using a good quantitative analytical method that is accurate, reproducible, and easy to obtain is difficult and is definitely an area of active research in stress echocardiography. There's promising data in looking at tissue Doppler as well as 2D spectral tracking strain, but there are, of course, technical limitations with each, and not all data is supportive of their incremental above and beyond what we already get from regional wall motion changes or perfusion changes with contrast. Thus, we do not routinely perform these at the Mads-Minkowski, but it's good to know that they exist. Certainly, there's a number of factors that will affect our accuracy. With the hypertensive response is defined as a systolic of above 182 and diastolic above 96 with the beaming stress, and the systolic above 220 with exercise. Typically, patients with a hypertensive response are more likely to have stress-induced ischemia as compared to those with a normal blood pressure response, but these are not likely to be more false positives. Currently, microvascular disease is a possible explanation for the development of wall motion abnormalities in the absence of angiographically significant coronary lesions, alongside other entities such as endothelial dysfunction, vasospasm, and small vessel coronary artery disease. Often, a strongly false positive study involves the mid-left ventricular segments or an atypical array of segments. The outcome studies have shown that patients with false positive stress echoes have similar outcomes to those who have true positive results. And thus, these patients should be carefully monitored and have aggressive risk factor modification. Unlike nuclear studies, left bundle branch blocks don't tend to cause more false positive results in stress echo, as alluded to by the ASE. And wall thickening is a very specific marker for ischemia that we can use to augment our results. Lastly, when properly performed, the perfusion imaging, as I've shown 2 slides ago, has significantly increased the sensitivity of detection of coronary stenosis during both vasodilator as well as debridement stress. In terms of what that means for the patients, so those who have normal regional wall motion at rest as well as with stress tend to have a very benign prognosis with a low event rate of 0.9% per year for the next year. And this approach is that of a normal age-matched population, as well as those who have normal coronary angiograms. Compared to a normal exercise stress echo, debridement stress echo tends to have a slightly higher event rate just because those patients tend to be more comorbid, more fragile, and less mobile, hence why they went for a pharmacologic stress echo in the first place. And there's data that show that inability to achieve targeted heart rate during dopamine stress echo is associated with a higher event rate than a normal dopamine stress. Other measures, such as the wall motion score index, which I didn't really talk about too much, an intermediate wall motion score index or LV ejection fraction of less than 45% further augments patient risk. Patients who have very extensive wall motion abnormalities, they're predicted to have a very high event rate of around 6.7% per year. Just going to end off with this figure from the 2014 CCS guidelines for the management of stable coronary artery disease. So in terms of things to remember, high-risk studies are those with wall motion abnormalities involving more than 2 segments or at least 2 coronary beds. Otherwise, developing wall motion abnormalities at low doses of stress, defined as under 10 mics per kilo per minute of dopamine or at low heart rate under 120, they're high risk. Next, I have a case of stress that we performed with the Mazakowski that I hope to encapsulate a number of things that we talked about here today. So typically, we acquire images at each stage in the apical 4-chamber view, the apical 2-chamber view, 3-chamber, parasternal long axis, and parasternal short axis. We also do an angle view to better capture the basal septum. Start playing again. Videos are very graphically intensive. So this is the apical 4-chamber view. You can see that there's already some degree of apical hypokinesis at rest. Which improves to a degree with stress, low dose dopamine. The peak stage and recovery stage. And the apical wall motion worsens again at peak. Here, the biphasic response. 2-chamber view study. Play. Basically, at rest, we can already see some degree of mid to apical anterior wall hypokinesis, which improves with low doses of stress, although this view is a little bit foreshortened. But the basal inferior wall is also relatively hypokinetic, which stress really get too good a view here, as is often the case at peak stress, with both bicycle as well as dopamine stress with the patient's respiration as well as heart rate going up. It can often be difficult to acquire peak images, which is why early recovery images are so valuable. Early recovery, we certainly see that motion, which is worsened compared to low stress. Chamber view. Much here besides that, we see again the apex is relatively abnormal, but there's also a degree of basal wall hypokinesis. That your wall hypokinesis improves somewhat with low doses and medium doses of stress, and it could relatively improve higher doses of stress. Generally, the parasternal long axis and short axis views are more used as confirmatory views to confirm our findings. So it's not really playing too well, but again, these confirm that there's that basal posterior segments, which is hypokinetic and improves with stress. Especially the short axis view taken at the mid ventricle is confirmatory view, and we can see there's an anterior wall motion abnormality, which played a little bit more smoothly. But I'll just describe it to you. That again improves somewhat with low doses of stress, but then again at peak stress, you can see that abnormality come back. The conclusion for the study was that the patient had a normal LV ejection fraction at rest as well as with peak exercise. There's a biphasic wall motion changes in the LAD territory. In the RCA territory, as we saw in those basal posterior inferior segments, there's a non-transmural infarct in that they had a resting wall motion abnormality that improved with stress. But given that this is involving more than 2 segments, then it is deemed a high-risk study and the patient was recommended for a coronary angiogram. So sorry about the technical difficulties, but in summary, stress echocardiography is a very valuable and versatile modality. We can use it certainly a wide range of indications. There are multiple protocols out there with its own advantages and disadvantages. And it gives us also further additional useful information about diastology, pulmonary pressures, and the presence of any valvular dysfunction. End of my talk. Thank you for your time.
Thanks so much, Peter. That was a wonderful talk. We will throw it open to questions. People online can either type something into the chat box or just turn on their mics and ask a question if there's a moment of silence. I'll start off asking the room any questions off the bat. I have a question for you. So Edmonton and Calgary, although we're in the same jurisdiction, we have quite different ischemia workup protocols. You know, Edmonton obviously does a lot of stress echo. We don't do so much. I think they do a little bit more CPA. We do a lot of nuclear, and we have a pretty robust cardiac MRI perfusion. I'd like to just get your insights, having seen both worlds, what you think about the 2 different kind of structures of ischemia imaging. And then secondly, if you were to come in and design how to do stress perfusion imaging, would you just set up programs as kind of a random distribution of cases through technologies, or would you encourage?
Excellent question, Dr. Howard. So the way I've seen things done differently is certainly, as we know, in Edmonton, slightly set up slightly differently in that each hospital is a different group, whereas in Calgary, we're one group. So typically for chest pain assessments, at least at the Mazankowski, a lot of the times I've seen patients referred for a stress echocardiogram on the same day that they have a clinic visit. So that way, you know, in someone who's never had an echocardiogram or a stress test in the past, they come in and get a limited echo, which screens for any valvular disease, any diastolic dysfunction, any pulmonary hypertension, as well as get the exercise or dobutamine stress echo. And that gives the provider lots of information to see them all that available to them. In terms of referrals, certainly the majority of our ischemia referrals at the Mazankowski come from practitioners at the Mazankowski. Small minority from the other sites, as they tend to keep within their sites. So in the other sites, they might use the CT angiograms more or nuclear studies more. A lot of the referrals from the other sites tend to be more valvular related. So one of the ways that I think we are able to achieve such a high volume is that because the Mazankowski is the only site that performs stress echoes. So there's a high degree of expertise in both the sonographers as well as the echo readers. And certainly having that institutional expertise is very important for having a robust echo program, because you need the volume to be able to be confident in your findings. So one of the ways I've seen things set up is certainly having a clinic that runs parallel to the stress echo days. And so the patient have that at the same time, or rather just before the clinic visit, and right after the stress echo is performed, the clinician with that information. Yes, Dr. Kamla.
How much does the echo cost versus a nuclear study? Stress echo.
Excellent question. In terms of the costs, I don't have specific numbers with me, but you have to take into account that typically to run a stress echo, you typically have a nurse there who's dedicated for managing the infusions of echo contrast as well as dobutamine. You have a dedicated sonographer who performs stress echoes throughout the entire day. And then we also have an ECG tech there to run the ECG part of it, and then the supervising physician.
Typically, how long does it take to do a stress echo?
We typically get 1 patient through per hour. That includes setup, takedown, but the stress protocol itself is usually 20 or so minutes.
Many of our people can't get on this treadmill. Do you have the same protocol with the bike, or?
Yeah, so The requisitions that come in are typically screened by the cardiologist who sends them, who usually appropriately sends them for bike versus dopamine stress. And certainly we pre-screen these patients before we bring them into the room, but the room is set up to be easily configured to swap over to bicycle versus dopamine.
Anybody online wanting to speak up with a question? Thank you so much.
Hey, I have a question. Sorry, Svet Turkov here. Thanks, Peter. Great talk, great overview. I had a question about the stress perfusion protocol. I was just wondering, about do you guys do this routinely with contrast enhancement for all your stress echoes? And when you do it, how much DEFINITY do you use, and what infusion rate do you use?
Yeah, that's a great question, Svet. So at the Baskowski, we do routinely perform contrast echoes or contrast enhanced studies for all of our patients. The only cases where we don't tend to use contrast are ones where we have a recent echo and we know we're doing it for things like low flow, low gradient aortic stenosis, or looking for hypertrophic cardiomyopathy and outflow tract gradients. So yes, for every ischemia study, we do tend to use DEFINITY. Each study uses one vial, so the nurse prepares it into a 50 cc syringe, which is infused at a rate of 1 cc per minute.
And will you guys routinely do flash imaging, reperfusion imaging, or mostly just wall motion analysis?
Yeah, so in patients who have a fairly low intermediate risk, we don't tend to do flash analysis if their wall motions are normal. If they do have abnormal wall motions, we typically will do flash reperfusion to look for any perfusion defects. And then in those who have a high pretest, fairly higher pretest probability, who have otherwise no wall motion abnormalities that we could detect, we also do recovery stage imaging to look for any potential new wall motion abnormalities. And in these patients, we also do the flash just to further reassure ourselves.
Great, thank you.
Of course.
Anyone else? Sorry about that, Scott. If not, we will close off our section and thank Peter for his talk.